This year at the STS, we participated in STS University, specifically in the course on mitral valve repair. Mitral valve repair has been mystified. It's been turned into this magical operation that only people with Harry Potter-like skills can achieve. It's not that complicated, and there's nothing mystical about it. The focus of our talks on mitral valve repair was on simplifying the procedure, on making it accessible to virtually all surgeons. And the truth is, 95% of degenerative mitral valves can be repaired with only 5 techniques. So 5 techniques for 95% repair. What are the 5 techniques? Let's list them. For posterior leaflet prolapse, triangular resection or sliding repair. For anterior leaflet prolapse, creation of artificial cords. For prolapse at a commissure, close the commissure. And then the 5th technique is an annuloplasty, which should be incorporated in every single repair. Let's break this down. Posterior leaflet prolapse is the most common lesion in degenerative disease, and fortunately, it's the easiest to treat successfully. For segmental posterior leaflet prolapse, meaning there's only one segment, usually P2, that has ruptured or elongated chordae, segmental prolapse, do a triangular resection and put an annuloplasty. That's it. Simple, reproducible operation. If you have extensive posterior leaflet prolapse and a tall leaflet, resection plus a sliding repair will treat the prolapse and prevent postoperative SAM. That's all you need for posterior prolapse, triangular resection or resection plus sliding repair. Anterior prolapse is judged in general to be more complex, but it's actually simpler to treat anterior leaflet prolapse. Make artificial cords out of Gore-Tex or PTFE, CV4 or CV5. Those are the sutures. How do you measure the artificial cords? That's always the tricky part. Here's how I like to do it. I identify the segment of the anterior leaflet that prolapses, and I take a CV4 Gore-Tex and take one of the needles and put it through the papillary muscle near the tip. So now I've got a stitch through the papillary muscle and 2 needles. Each needle comes up through the anterior leaflet twice, from the ventricular side to the atrial side, then again ventricular to atrial. So it's a figure of 8. The 2 needles finish near each other. Usually I will put 2 sets of cords, so 2 Gore-Tex sutures for the anterior leaflet, but don't tie them yet. Now put your annuloplasty and then look at the valve and look at the reference point, which is usually A1. Lift A1 as far as you can past the annuloplasty and make it so that your new cords hold the leaflet to that level. You usually want to be able to lift the anterior leaflet a little bit past the annuloplasty, meaning make the cords a little bit longer than you think they should be. So that's anterior leaflet prolapse. Make new cords, but don't tie them. Put your ring in, then measure the cords and tie them. Prolapse at the commissure. This makes a really complex jet easy repair. Simple. Close the commissure. Just sew it shut. You can sew about 20% of the valve shut, and as long as you don't undersize the annuloplasty, you will not have mitral stenosis. So prolapse at the commissure, close the commissure. It's like an Alfieri stitch at the commissure. And finally, an annuloplasty. Every repair should have an annuloplasty. Which type of annuloplasty should you use? It's up to you. They all work just fine. I favor a posterior band, which works very well. It's flexible and it's easy to place, particularly with minimally invasive techniques. But the key point with the annuloplasty is, as they say in Nike, just do it. You've got to have an annuloplasty to complete every repair. Mitral valve repair is neither mysterious nor magical. It is accessible to all of us.